let's go and get started. Well, welcome everyone to our series of Buncke Clinic virtual visiting professors. For those whom I have not had the pleasure to meet in person, I'm Bob Axapha on behalf of myself and Greg Buncke, Rudy Buntic, Andrew Watt, and Walter Lin. I want to welcome you. Our speaker this morning, we're delighted and very honored to have a dear friend of mine, Dr. Jonathan Isaacs, as our virtual visiting professor today. Dr. Isaacs is the Herman and Vera Nachman Distinguished Research Professor and Professor and Chair of the Division of Hand Surgery within the Department of Orthopedic Surgery at the Virginia Commonwealth University. Jonathan is really a thought leader in the field of peripheral nerve and peripheral nerve surgery, and he's really a clinician scientist. He has an active lab. He has numerous grants from government, military, industry. And it's this unique combination of clinician, educator, and scientist that's pretty rare to find these days. And he's not only a very respected colleague and thought leader in nerve surgery, but I consider him one of my closest friends. Over the years, I've gotten to know him quite well. We've taught courses together. We've been on panels together. We've traveled to various courses and programs. Here it's last year when we actually could travel to the Gilbert Nerve Symposium. And with that further ado, I will go ahead and hand the control over to Dr. Jonathan Isaacs. Jonathan, I'm going to make you a presenter, and you're going to see a little notice to accept that, I think. There we are. Did it come over?
Yeah.
All right. Well, thanks again for being with us, and we're looking forward to your talk.
Babak, thank you for the invitation. That you didn't, I don't know if I'm allowed to say this type of thing, but that was the brandy you showed us drinking in that last picture was one of the best drinks I've ever had in my life. So thanks for bringing back that memory of a wonderful trip. And Babak truly is one of my best friends as well, and I appreciate him introducing me that way. Though I think he tells everybody that they're one of his best friends. So I don't know, but anyway. So Babak asked me to talk and gave me a lot of freedom to pick my topic. And I like talking about nerve. That's where I do most of my academic work and where I talk about the most. But I struggled thinking, well, what could I share with the people in the Buncke Clinic? The Buncke Clinic is full of superhero surgeons. I mean, what could I share that you guys don't already know and don't already talk about and don't already teach your residents? So what I'm going to do is I'm going to spend the first half hour and I'm going to talk a little bit about kind of my philosophy and gestalt on where we are with nerve repairs and where what we're doing right and what we need to do a little bit better. And then I'm going to take a little bit of liberty as Babak has offered me, and I'm going to spend the second half of the talk sharing with you some of the stuff that we've been working on in our lab that I consider innovative, hence the title, though whether or not you consider it innovative, you'll have to decide at the end of the lecture. But hopefully it'll give you some good food for thought. If we have time, I'd be happy to talk about anything that we bring up or any other aspects of nerve repair that anybody wants to pursue a little bit. So Babak is probably tired of seeing this slide. I start off most of my nerve lectures with this slide, but it's really, I think it really sums it up well where we are with nerve repair, that when you talk about the type of result you would want to have if you were a patient or if it was your family member, I mean, the chances are about 50-50 that we achieve that goal. Certainly that's better than odds than doing nothing. If you don't try to fix the nerve, you know your chances of recovery are zero. And if you go to the literature, I guess the authors try to make each other feel a little bit better because they list M3 muscle recovery as a good result, and maybe for finger extension that's okay, but I think we can all agree that if we were the patient and we had a nerve repair and we got M3 back, we would not be high-fiving the surgeon that helped us get that. And I guess you could barely high five because you'd be able to lift your arm against gravity and then let it fall against the surgeon's hand. But it's certainly not what any of us would really want if we were the patient. So we really have a ways to go. And if you kind of start with that as the premise and then think, well, okay, well, why is it that repairs do so poorly? It's truly a multifaceted problem, and it starts that some of the nerve cells don't even have a chance to regenerate. We know, especially the sensory neurons, that many of them die from the trauma of having the nerve trunk cut. We know a big part of it is axon regeneration, that axons go the wrong way, they get lost, some of them, as they're regenerating, just kind of peter out and stop regenerating. We know about atrophy is a big issue. And cortical plasticity, we don't talk too much about it. Occasionally, some researchers come up and focus on it, mostly when they're talking about sensory retraining and that type of thing. But if you think about it, you cut a nerve, it gets fixed. The axons that regenerate, assuming they make contact, it is not going to be the same connections that were there prior to the injury. So the brain has to now interpret different signals or send out different signals to elicit motion. And this is going to take some reprogramming of the brain, if you will. And obviously some brains are better at doing this than others. And certainly one of the reasons why there's probably a difference in outcomes related to patient age. This list is kind of, I mean, where we are. I think most people would agree with this list, that when we talk about nerve repairs, time is your enemy. The longer it takes for you to do the repair, the longer the regeneration length, i.e. the longer it takes for those axons to reach their targets, the worse your result's going to be. Suturing scarred or injured nerve to scarred or injured nerve gives you more scar. You cannot get good nerve regeneration with that recipe. Tension is bad. We say this over and over again. But I have to tell you, I think that it may be one of the areas that we're a little too dogmatic about and over-interpret a little bit too much. We try to come up with objective ways to say that there's tension, and one of the popular ways is to say, well, if you put a 9/0 nylon stitch across the nerve or an 8/0 nylon stitch and it can't hold the nerve ends together, you have too much tension. The problem with that test is that if you have a patient who has put their hand through a window this morning and you operate on them tonight and try to put their median nerve back together with the little bit of natural tissue retraction, with the swelling that's going to occur, there's a good chance it'll fail that one suture tension test. And if that's the case, then we would be grafting almost everything. And I will tell you that the results of grafting are much worse than the results of direct repair when direct repair is appropriate. And that's where it gets onto a little bit of a slippery slope, I would argue. And I think we have to think a little bit more carefully than we have in the past. Christoph Oberlin presented at a meeting a few years ago a patient that had a sciatic nerve injury and with a segmental gap, and he asked the audience, well, how would you guys fix this? And he picked on a couple of people in the audience who said, I grafted, I do this, I do that. And nobody said what he wanted them to say, which is what he did, which was essentially to flex the knee 90 degrees, put a cast on, keep it at that angle and get the nerve ends together. And then after 4 to 6 weeks, straighten the leg out. And the reason why nobody would say that is because it goes against this big principle that we talk about. Well, he showed a patient that had unbelievable recovery from that sciatic nerve injury, and there's series out there. He's part of them. He's part of some of them, but there are series out there that say that this is a viable option and can get very good results. And so I think a little bit of the issue on tension even goes back to some of the military conflicts, World War II, even the Vietnam War, where they had these terrible results after nerve repair, and when Hanum and Lacey came out and said, well, it's because you're doing your repairs when you should be grafting them, I'm not discounting the importance of that, but I'm saying there may have been other factors involved, such as failure to adequately resect the zone of injury and then graft. And this concept that that tension is any tension at all is going to lead to failure. I'm not sure that it's true, and I suspect that other people over the next few years may shift their stand on it. You cannot look at the clinical literature and see the remarkable difference in a direct repair versus a grafted repair and not think in terms of, well, how do we get more direct repair? So that's my diatribe on that topic, which I think certainly could elicit some discussion if we want to go in that direction. The last principle is that you have to get the axons directed into the endoneurial tubes, and we'll talk a little bit more about that in a few minutes. So the problem starts as soon as the nerve is cut or has a full thickness injury. When the axon's disrupted, the distal axon, as we all know, degenerates through a process called Wallerian degeneration. Phagocytic Schwann cells, macrophages invade the area, clean up the debris, and leave empty endoneurial tubes that, if it's a injury in continuity, the axons can then regenerate down those endoneurial tubes, or if you have to repair the nerve, that hopefully you get your repair good enough that the axons can cross or bridge the short zone of injury and get into the endoneurial tubes on the other side, and then they regenerate. But the problem is they regenerate very slow at 1 millimeter a day or 1 inch a month. So even if you do an acute repair, if it's proximal enough or far enough away from its end target, it can take a really long time for those axons to reach their target. And during that time, the muscle, we like to focus on the muscle because we could see it shrivel up and get small. We could see that the person can't use the muscle. It undergoes denervation atrophy, which is characterized by a loss of muscle mass, loss of muscle fiber size. Contractile composition actually changes within the muscle fibers themselves, and with enough time, the muscle gets replaced with scar and fatty tissue, kind of at the farther end of the spectrum. But the longer you wait, the more denervation atrophy you're going to have. I said that we like to talk about the muscle because we could see it, but there are many people that think that the distal nerve stump being denervated is even a bigger deal, that with time, and this is one of the, up on the screen is one of the animal studies that try to demonstrate this, but with time, when a distal nerve stump is chronically denervated, though you could apply the same principles, honestly, to chronically denervated nerve graft material, but with time, with chronic denervation, the nerve loses the ability to support regenerating axons, and this seems to be related to an accumulation of impeding conjoined sulfate proteoglycans, to a loss of guidance cues, and to a change in the Schwann cells. The Schwann cells enter, we call it a state of senescence, but you could think of it as they're alive, but they're kind of sitting on the couch watching TV with a beer on their belly, and they're not doing their job. They're there, but they're not doing what they're supposed to do. And this, the other way to think about this is that the nerve has lost its neurotrophic and potential, or the neurotrophic environment has degraded in the distal nerve stump itself. So when we actually do a nerve repair, and thinking about these principles, we know that there's some key steps. We have to cut back damaged nerve. We have to cut away neuromas on the proximal stump, gliomas. So they're not neuromas in the distal stump because there's no nerve there. It's only connective tissue. But you have to cut away the abnormal nerve on both sides and make sure that you're repairing a good quality non-scarred nerve to good quality non-scarred nerve. We do know that tension is bad. I know I went on this whole diatribe about how you have to think about natural tension and swelling when you do your repair, but in no way am I debating the concept that tension is harmful to nerves, that it decreases the blood flow either transiently, or if there's enough tension, at least in animal models, it decreases it permanently. It affects the Schwann cells, it affects axon regeneration. So we know that tension is bad, but as I've I've kind of alluded to, that doesn't mean every time you have a little bit of tension that you have to jump to some sort of bridging device. We know you can mobilize the nerves, particularly the median nerve in the forearm. You can gain 4 to 6 centimeters just by releasing the tissue over the median nerve. The ulnar nerve, we all know we could transpose it at the elbow to get a little bit more length at the elbow, a little bit more length above the elbow. Doesn't typically help too much in the forearm. Transposing the ulnar nerve from Guillen's canal into the carpal tunnel can give you another centimeter or two, though it's probably a fair amount of work for that amount of gain. And then I would say that there is a place for a little bit of joint positioning, at least temporarily, and in certain circumstances that you can splint the nerve and protect it, and you don't have to, every time you think there's a little bit of tension, immediately go to some sort of bridging device. But it becomes a little bit of a subjective call that I might argue. When you need to bridge it, when you do have a gap that you can't get together, when you do think there's too much tension, there's a fair number of options. I'll mention conduits. I know that Bobek and Greg, I don't know about your other partners, but I know you two are very allograft focused. But certainly there are plenty of people out there that use conduits, and conduits are based on some sound ideas. I mean, first of all, the concept of having a off-the-shelf option is convenient. It certainly, when you find yourself with a small gap, certainly makes it easy to deal with it if you're worried that you might have too much tension. And even the physiology behind them is pretty well recognized and pretty established. You have your nerve stump in both sides of the conduit. You get a fibrin exudate that forms this scaffold and this clot that is essential to allow Schwann cells to migrate across. You have to have Schwann cells to guide axons. So the Schwann cells have to migrate across, and then the axons can elongate as well. And in certain circumstances, this clearly works. This is a silicone tube that you see up on the screen on the left side. There's a nerve stump in one end, a nerve stump in the other end. You close it up, you come back later, and you have nerve that is grown across it. You cannot debate that. That is regenerated nerve right there. So it clearly can work. It's clearly based on sound principles. The problem is that as I mentioned, you have to have that scaffold. You have to have that fibrin clot has to mature and be stable and strong enough that it's able to support those migrating Schwann cells and subsequently elongating axons. And this fibrin clot becomes less stable at longer lengths and bigger diameter nerves. And you can look at the screen and see where there's a silicone tube that clearly that fibrin clot did not form well enough to act as a good scaffold, and you don't have good nerve regenerate there. So the question then becomes, all right, well, what's the length that I could use a conduit where it's predictable that that fibrin clot would form? To me, that's really how you have to kind of look at that question. And I have other talks where I show all these pictures of different textbooks and different review articles to make the point that everybody throws around this number 3 centimeters. That 3 centimeters is the magic number that conduits can work for. Well, there is some non-human primate stuff that shows, yeah, it could work at 3 centimeters, even up to 5 centimeters in those models. But most of the data comes from this Weber study written back in 2000. It really, certainly at the time, was, I think, considered a pivotal study. And on the surface, it was done really well. A prospective study, conduits versus direct repair or autograft for digital nerve repairs. And they came up with this conclusion that the conduits were better for defects of up to 3 centimeters. But there's a couple problems with it. The first one is that they did have patients with gaps that they directly repaired, probably inappropriately. Well, that kind of biases your direct repair autograft group for some failures that you might not have had otherwise. And for the conduit group, they had no defects of up to 3 centimeters. So it's very hard to say that conduits work for defects up to 3 centimeters when you don't even have any patients in that group to validate that claim. The longest gap, 25 millimeters, that didn't even work so well. And the mean gap was 7 millimeters, which certainly is a big difference from the 3 centimeters that they claim. So it's a fairly flawed study. It gets, the information from it gets propagated quite widely. And I and others have argued that these authors probably ended up hurting patients and probably ended up hurting the conduit industry, because they really set them up for some failures that they might not have had to absorb. And if you go to other studies, Battiston and all, Lohmeyer and all, you can certainly validate this concept that when you get into longer gaps, the potential for recovery really plummets. And then if you go to bigger diameter nerves, major peripheral nerves, it's even a less optimistic view. This on the screen, I think it's hard to tell what that is. I zoomed in too much. But that's from several years ago. That was a median nerve in the proximal forearm that had been fixed at an outside facility with a reported 3 centimeter gap using a conduit. And that's what we found when we re-explored him several months later. Clearly inadequate nerve regenerate. 4 out of 4 failures according to a study by Amy Moore's group, and 11 out of 12 failures by Shiriak. So really bad track record, probably not a good idea for conduits for these major peripheral nerves, with the exception that if you focus on very small gaps, and by small gaps like 5 millimeters-ish, they seem to work well. And that's, I think, helpful information, but it's more helpful in terms of that you can use a conduit really as a nerve connector, but it's unlikely that 5 millimeters is the make or break with regard to the amount of tension that your repair is under. So I said conduits have a lot of good things about them. Off-the-shelf convenience. They can work in certain circumstances, but there's this whole scaffolding issue. And so if you are like me, when I first kind of digested this information, you should be saying to yourself, oh, why don't they just make a conduit with better scaffolding? And I'll tell you that they are. They will. They are. We already see some of the next generation of conduits coming out with some different form of scaffolding. It'd be nice if they're able to get in some guidance cues, and some people are trying to put in growth factors by different local factor delivery methods. But if I said, okay, yes, we're all in agreement then that they should put scaffolding into a conduit, and I said, well, what do you think the scaffolding should look like? Well, what I would say, and hopefully you agree with me, is that it should look like the inside of a nerve. And the problem with that, with regards to the current people trying to develop the next generation of artificial conduits, is that this product already exists in the form of nerve allograft. That nerve allograft, and the most fundamental level, you could think of it as a nerve tube with scaffolding that looks just like the inside of a nerve. And based on that, even if you don't accept anything else other than that you accept the concept that conduits can work in the right circumstance, if you accept nothing else other than that, then certainly allografts have a place in our nerve repair toolbox. Now, that doesn't mean that allograft is always going to work. Very similar to the story I told you about conduits, although now you do have the scaffold, but you still have to have that Schwann cell migration into and across the scaffold before it'll support axon elongation. This is, I won't go through these pictures, but that's what this study has demonstrated. Well, it turns out that if you take a acellular nerve allograft and make it really, really long, and this is a study in a rat, and you could see how long that graft is, because they can't even put in a straight line. They have to kind of make it curved and stick it up into a subcutaneous pocket in the rat. But if you take a really long, like 40, 60 millimeter long allograft and do repairs with it, you don't get very good regeneration in this animal model. And this picture of the right side, I'll spend a second and take you through this, because this is kind of interesting. That this is from a genetically modified rat called now I'm forgetting what it's called, a green fluorescent GFP, sorry, a green fluorescent protein modified rat. And just as the name implies, there's a protein in the axon that under the right lighting condition puts off this green fluorescence. So if you look, I don't know if, can you see me, Bobek, pointing on the screen? Is that transmitting for you guys?
Yeah.
Okay.
Yeah,
so
we can see your mouse.
Okay, good. That's what I meant. So, okay, so if you look at this is 20 millimeter isograph, you could see the green fluorescence going all the way across. This is 20 millimeter acellular nerve allograft. You could see the green fluorescence going all the way across. When you go to 40 millimeters, now that's real long for a rat, but with autograph or isograph, you see it going all the way across. Now, when you go to the acellular nerve allograft group, it's only going about halfway across. So it's not making it all the way around in this model. And then when you go to the 60 millimeter group, geez, for 60 millimeters, even for the isograph, you don't see a whole lot of green fluorescence going all the way around, but you see it getting all the way around. But for the 60 millimeter group, it's not only not going all the way around, it's not even making it to the 40 millimeter or to the 20 millimeter point that it made for the 40 millimeters. It's only going about 5 or 10 millimeters. So it's not a length dependent problem that axons will only regenerate 20 millimeters through acellular nerve allograft. It's more complicated than that. And it seems that there is something that happens, most likely, there's several theories being developed right now, but most likely it's something happens to the Schwann cells where in that environment of a really long acellular nerve allograft, the Schwann cells go into that senescent state that I talked about earlier. So the environment is not supported to regeneration as opposed to a true length-dependent problem with the axons. So I think that that's very interesting, and we'll talk a little bit about that situation in just a minute. How you take this and apply it clinically, I've always struggled with that. If you think about 6 centimeter graft is much longer than a rat hind limb, hence why you have to push it up in that subcutaneous pouch. So if I took Bobek and I cut out his sciatic nerve and I grafted it and it didn't work, nobody would say, well, what kind of graft material did you use? They would say, of course it didn't work. You tried to graft the length of his entire nerve in his leg. And so it's hard to say how to translate this 6 centimeters from a rat to humans, other than to say that there clearly is a critical length for acellular nerve allograft, that at some point it's not going to work well. At what point that is becomes a little bit harder to determine right now. So the next, sorry, I segued a little bit to get back to finish up kind of the focus on the steps to repair. The next step obviously is to obtain alignment. And when we talk about alignment, at least in the literature, it almost always seems to focus on getting a fascicle pointed at the correct opposite fascicle, so the correct distal stump. And the reason why we talk about that a lot in the literature is because the body does not do a great job of sending axons to the correct target. This is called end organ specificity, but the body doesn't do a great job of saying motor axons go to motor end plates, sensory axons go to sensory end plates. We think it does it a little bit. It's called preferential motor reinnervation, is the leading theory still, which basically says that the motor axons seem to be able to decide which endoneurial tubes they're going to go into. The sensory axons seem to be a little bit more random. Once the axons realize they're in the wrong place, they kind of prune back, and it's a remarkably inefficient regenerative process. And that's the way most of us talk about the importance of alignment. But I'll tell you that what gets overlooked is, yes, it's important to get the fascicle pointing towards the correct fascicle, but I will tell you even more important than that is to get the fascicle pointing at any fascicle. And it seems intuitive, it seems obvious, but when we talk about it, people really kind of look at us like we're crazy. Well, what do you mean? There's not a problem with that. Well, there definitely is a problem with that. And we know this. I'll tell you, I haven't done it in a while, but one of the ways me and Bobak became such good friends is we taught some axogen courses together, and they would have a big, a part of their courses was a cadaver lab, and we would walk around the cadaver lab and look at not residents, I mean people in practice doing nerve repairs, and their fascicles would be pooching all over the place, and they really didn't seem to appreciate that this was an issue. We studied it. We went to a cadaver lab and we did cadaver nerve repairs, and about 40% of them looked something like what you see up on the screen there. The fascicles kind of pooching out to the side. Now you can see how Bernstein also referenced. He did a study looking more at the need for magnification. They compared microscopes, and they compared loop magnification, and also did a cadaver study. And it turns out that probably the microscope is a little bit better, and that's interesting. But kind of hidden in their data, they didn't even recognize it, at least according to their discussion. 40% of all of their repairs were unacceptable. The exact same thing that we found when we kind of repeated their study, which to me is remarkable. If you don't get the fascicles facing each other, how are you going to get the axons to regenerate across that zone of injury? And if you think about the picture I just showed you, with the fascicles pooching out to the side, well, that's where the person was so lazy that he didn't even bother trimming back those fascicles. But if that's what the outside of the nerve looks like, then I think you could appreciate that the inside of the nerve may also look something like this. So you may really have, I mean, I don't know, we didn't peel away the epidermis and look inside the nerves. Maybe that would actually be interesting to do. But I think that people tend to over tighten their repairs. It makes the outside of the nerve look a little bit better. But if your fascicles aren't pooching out the side, they certainly may be pooching to the side inside the nerve, as demonstrated in that drawing right there. And finally, once you have the alignment, yeah, go ahead. Do you have something, Bob? So the
no, I think somebody didn't have their mic off, I think.
Okay, no problem. So then we got to get the nerves to stay together. Coaptation, suture is still considered the gold standard. I would say it's certainly limited by the technical challenges. What I just showed you, those are suture repairs with the fascicles pooching out of the side. It is time consuming. Again, I think the surgeons at the Buncke clinic are so technically good that maybe for them it's not as time consuming, but for most surgeons, suturing nerves is time consuming, which means it's resource expensive. So that's also problematic. And sutures do generate some scar tissue, and they do it at the effacement where the two nerves are facing each other, which can be maybe a problem as well. Because of that, it's not surprising that people have been looking for alternative solutions, alternative ways to hold the nerve ends together, literally for decades. One common way I think probably most people on the video chat are familiar with is using fibrin glue. Just in case there's some people not familiar with this process, I'll briefly tell you that basically fibrin glue, you can get it as a commercially available product. You have the components of the clotting cascade that are in two separate syringes. You squirt the two syringes at the same time, and the proteins kind of mix and start the clotting cascade, ending with the thrombin activating the fibrinogen, and you get this white gel-like clot that you see up on the screen around a approximated nerve stumps. And it's white because it's a clot, but it doesn't have red blood cells in it, so it doesn't look like what you'd be used to looking like as a clot. And this is quick. It definitely is atraumatic. If you get some fibrin glue in the coaptation, it doesn't matter. It won't block regenerating axons. I would argue that if you don't do it as an adjuvant to sutures, meaning if this is your only repair technique, then it lacks adequate holding strength. We did a biomechanical study that showed that it didn't add any mechanical holding strength over a couple of stitches. It did resist gapping, which I think is probably important and reasonable reason to use it, but I would caution you that biomechanically fibrin glue clearly is a little bit of a riskier approach to coaptation. We did this study just recently. We just submitted it to Journal of Hand Surgery. We've not gotten the review back yet, but essentially we looked at the literature on fibrin glue, and we thought it was a little bit skewed because the studies in animals, they always cut the nerve and then immediately fix it. And that's not real life. We didn't think that mimicked what we saw clinically. So we wanted to make it a little bit more relevant. So what we did is we went to the rats, we cut the nerve, we waited 3 days. Maybe we should have waited longer in hindsight, but we waited 3 days to get a little bit of that early retraction. And we went back in, we trimmed the edges. So you did lose a little bit of nerve length by us trimming the edges, and we did the fibrin glue repairs. I will tell you that if they held, they did fine. They did the same as sutures and are a good way to fix the nerves if they hold. But just exactly the warning I'm giving you regarding the biomechanical studies, we went in on several of them for day 3 evaluation, and they had dehisced. They have come apart. So it is something to think about. It is something to worry about if you are going to pursue a fibrin glue as your only coaptation tool. All right, so that's kind of, as I said, that's kind of the principles, my kind of philosophy on it. Obviously, some of it is my opinion, and you may agree or disagree. So I've been thinking about nerve problems for my whole career, as Bob Beck alluded to. I think that that's one of the big differences when you really do research. You think about the problems all the time, and I'm just going to share with you some of the cooler ideas that we've had. Some of them may end up being successful, maybe not, but I still think that they were kind of interesting ideas that I'll share with you over the next half hour. And the first, can we improve denervation atrophy? Then I'm going to talk about improving axon regeneration, and then I'll finish with what I think really out of everything has the potential to be a true game changer. So we talked a little bit about denervation atrophy and that it's a problem related to the length, the time it takes for axons to regenerate, or possibly the timing of doing your repair. And if you want to avoid denervation atrophy, it certainly makes sense that you should get the axons to regenerate faster or get your repair closer to the target. Both of those things are great ideas and make perfect sense. And sometimes at least getting your repair closer to the target using a nerve transfer is a viable option. But to date, we have not made any progress in getting axon regeneration to be significantly better. There are some things out there that I'm not going to talk about unless somebody brings it up later for discussion. But there's nothing that has really been shown to make a difference in speeding up axon regeneration. So you at least based on our current tools and what we know, you are going to have muscles that are going to have suboptimal recovery. And we've all seen this clinically, that they get some muscle recovery back. In fact, I alluded to it in my first couple slides, that we see a fair amount of M3s, but M3 really isn't what you wanted. So we started thinking, okay, yes, great, let's get the axon regeneration better. But in the meantime, is there a way that we could get our M3s to look more like M4s? Can we maximize the muscle that has reinnervated, get those small muscle fibers a little bit bigger, try to get them maybe even the hypertrophy to compensate for the muscle fibers that did not reinnervate or had already entered a state of irreversible denervation atrophy? And our first idea was to give the rats anabolic steroids. And we did a pilot study that seemed to show that this would work, that this should work, and we did a larger study and didn't see any effect. Now, we've all watched TV and we see the athletes and we see who takes anabolic steroids, and it seems it'd be very hard to convince any of us that anabolic steroids don't build muscle mass when taken the way these athletes do it. One of the problems is these athletes are not taking anabolic steroids as the FDA would recommend. They're taking huge doses. They're stacking them, they're taking them with growth hormones, they're exercising. So that's different than us just giving a bunch of rats some anabolic steroids and seeing if they would get stronger. By the way, there are physicians, Jamie Bertelli, I think he's going to talk to you next week, and you could maybe even ask him about this. I know that he currently, as part of his standard practice, does give his patients anabolic steroids to try to help their muscle recovery. So it is being used at least on that level, but from the work we did, we were not able to demonstrate a positive effect, though I would argue that we gave at a low dose. And when we thought about, well, if we give a higher dose anabolic steroid, maybe we'll see a more profound treatment effect. But then you have all the problems with high anabolic steroids. The rats get sick, they go into roid rage, kill their whole families. It can be problematic going into those higher doses. So we started thinking, okay, well, perhaps there's an anabolic option out there that has a safer risk-benefit profile. And if you look around, it won't take long before you come up with myostatin. Myostatin is in the TGF-beta superfamily of signal transduction proteins, and it is a muscle inhibitor. So the body makes it on purpose because we only want our muscles to be so big from a physiologic evolutionary standpoint. I think everybody could relate and understand that. So myostatin inhibits muscle growth. So on the bottom left of the screen, that is a genetic mutation in a breed of bull. It's called a double muscle or Belgian blue. And obviously the picture speaks for itself. On the right side of the screen, that's probably a more spontaneous genetic mutation, but that dog is also felt to have had a myostatin mutation. It's not developing myostatin. So myostatin seems like a very interesting potential target. And if you start looking at, well, how can I target myostatin? How can I inhibit myostatin and apply this clinically? You'll come up with follistatin, because follistatin is a well-recognized glycoprotein that blocks myostatin and also has its own independent stimulation. PS also has some other cool pro-regenerative properties: faster muscle healing, less fibrosis, stimulates satellite cells. Satellite cells, if you remember, are the kind of cells in the muscle that fuse with the muscle fibers to help the muscle fibers grow or regenerate when they've been damaged. So this picture I think is really cool and very compelling. So the left column, the control mouse, those are normal mice. You can see the skin's off and you can see the muscle tone. The middle column is missing myostatin. So that's the effect of missing myostatin in this mouse model. And again, you can clearly see much bigger muscles, much more muscle tone. The follistatin group on the far right, you can see why they call it a quadruple muscle effect. It is really, at least visually, very impressive what the effects of that follistatin are. And so we looked at giving rats follistatin. We denervated them for either 3 months, which is what I'm showing you on the screen, or 6 months. Now, we reinnervated them. So it was supposed to clinically be replicate what we see clinically: prolonged denervation followed by reinnervation, and trying to get the muscle back. And the longer the muscle should have been denervated, the harder it is to get the muscle back. So pay attention here to the middle column, or the second from the left column. I'm circling it with my mouse, and that is the temporarily 3-month denervated muscle given follistatin DNA that we injected in it, compared to the denervated muscle. It was our actual data was not very impressive because we had big standard deviations, which is problematic. But certainly you could see with your eyeballs that muscle is bigger. And when we went to the 6-month group, we could see, again, the key group probably is the second from the left that I'm circling, compared with denervated. Now I say it's denervated, it was delayed reinnervation. It was denervated for 6 months, and then you did the nerve repair. And you could see, to me, it's a huge difference. There we did show a statistical difference between those muscles in those groups. But anyway, but it's to me, it's a really cool concept that we may be able to augment the muscle that has recovered and maximize the functional benefit we could get from that muscle, even if we can't get more muscle reinnervated. But the concept of getting more muscle reinnervated certainly is appealing. There's a concept out there of trying to get as many axons to the target as fast as you can, and that's going to segue me into my. So classic.
Please turn your microphones off, whoever's mic is on. Thank you. Sorry, Jonathan, go ahead.
I mean, I can keep my mic on, right? So
yes, yours is fine.
Okay, thank you. Okay, so it's hard to make jokes because I can't even hear you do your. Usually you at least give me a polite pretend laugh when I make a joke, and with this format I don't even have that. So it's hard. This is the hardest thing about presenting through Zoom. So this was really the idea that launched me to become a nerve researcher. So the concept of endocyte nerve repair has actually been around for quite a while, though when in the past when we talked about endocyte nerve repair was specifically for the thing you see on the left side of the screen there. So imagine a situation where you have a cut nerve, but you don't have a proximal stump. and you don't want to sacrifice a donor nerve to do a formal end-to-end nerve transfer. Well, the concept was basically you took the distal nerve stump, you put it into the side of an intact donor nerve, so you're not sacrificing the donor nerve, and this process stimulated axons to sprout out of the donor nerve into the recipient distal nerve stump. And it can work. It's I would, without going into a lot of detail, I would tell you that it's a very inconsistent result, that you can see results with this, but it's not very reliable. And so most of the time, if it's used clinically, and I know Buncke uses it sometimes for sure, most of the time though, if it's used clinically, it's used in a situation of, okay, if it works, great, and if not, it's not a big deal. And that's fine, and I certainly support that. What we did is we basically reversed this relationship. We had situations where we had an intact damaged nerve, so it had decreased number of axons, but it had some axons in it, and we didn't want to throw away the axons that we had, but we wanted more axons in that nerve. And so in this case, we didn't mind sacrificing a donor nerve. We would sacrifice a donor nerve, but put it into the side of the injured recipient nerve, and the axons would flow in and add axons to this kind of depleted pool. And so because we kind of reversed what had been called a classical endoside nerve transfer, we called it a reverse endoside nerve transfer. That subsequently nomenclature was changed to supercharging endoside nerve transfer. And has actually become a relatively popular idea really very quickly. It became, I say quickly, when we described it, it barely caught any attention, but Susan McKinnon's group picked up the idea, advanced it, and with her support, it actually became a very popular concept really remarkably quickly. But one of the things that she and other people have claimed is that one of the appeals of this approach would be that it's going to babysit muscle. So you're going to get axons to the muscle, and those axons are going to preserve the muscle so you don't get all this denervation atrophy I was talking about. In the meantime, other axons would regenerate down and further innervate the muscle. And that's a very appealing concept, except I don't think it happens. When axons get to a muscle and they innervate some muscle fibers, those muscle fibers are innervated. The other muscle fibers around that have not innervated, they still go on to denervation atrophy. We know this from animal studies where you can go in and look at partially innervated muscle, and you can find pools of innervated muscle fibers intermixed with pools of uninnervated muscle fibers that are clearly going to go on to denervation atrophy. We try to look at this in the lab. This isn't quite a supercharging study, but we did a partial nerve repair, left it like that for several months, and then went back and revised it to try to get more axons. And I won't go into all the details. I'll tell you, it didn't seem to make an effect. We don't think that there is what I'll call a good neighbor effect. Having a few innervated muscle fibers don't really seem to preserve the other muscle fibers in that muscle belly, which I think is important, especially when we talk about the clinical application of supercharging and where you should really be using it. I think it's important to recognize that it probably doesn't really have a true babysitting effect. With that said, one interesting thing that came out of the work on supercharging is that it may have a babysitting effect, if you will, on nerve. So we talked about this chronically denervated distal nerve stumps lose their ability to support regenerating axon, that there's a decrease in the neurotrophic environment. And I mentioned you could see a similar phenomena in long nerve grafts. So here's a model in an animal, in a rat model of a long nerve graft that's supercharged with sensory nerves, but the graft supported more motor axons generating across it. So it really seems that the only way you can interpret that is that these supercharging axons improved the neurotrophic environment within the nerve graft itself. And then if you go back to that model of the chronically denervated distal nerve stump that I mentioned earlier in the talk about how you get all these changes in that distal nerve stump. Well, this study, they're doing what we call these bridge grafts, side-to-side bridge grafts. And essentially, you can imagine axons can come out of the tibial nerve, cross this bridge graft, and go into the chronically denervated distal stump of the peroneal nerve. So a variation of supercharging, if you will. Okay, so a variation of supercharging. And what these researchers found is that the distal nerve stump was protected. It didn't go into, it still supported axon regeneration even after being chronically cut, which is fascinating, and it really suggests that you can improve the neurotrophic environment in chronically denervated nerve or in long autografts. Well, another area that I personally am more interested in is the acellular nerve allograft, and as we already talked about, there is clearly a problem with acellular nerve allograft at longer lengths having an issue with the neurotrophic environment. So we look to see, okay, can you supercharge allograft and improve the function? And yes, you can. We showed that it improved the functional outcome if we supercharged a 60 millimeter acellular nerve allograft. And then we did this kind of follow-up study that say, again, using those bridge grafts that was in the drawing that I showed you a few minutes ago to 40 millimeter acellular nerve allograft, and showed not only improved functional recovery, but also showed that there were increased Schwann cells. So increased Schwann cells if we did the bridge grafts. So again, a very cool idea. How this translates clinically is a little more difficult if you have a donor nerve, unless we can show that a sensory donor nerve can do the same thing. But unless you have if you have a donor nerve that you could put in the side of a long allograft, well, most likely you're just going to do a direct nerve to nerve transfer. So I don't know that has a huge clinical application. Now, maybe those bridge grafts, you could probably imagine grafting the ulnar nerve and then doing some bridge grafts between the your allograft to your ulnar nerve and the parallel median nerve. Okay, so there may be some clinical translations of that concept, but to me the more interesting concept was that if you can get axons into the allograft, it'll help other axons grow into it. And that's what we've been looking at. This is a dorsal root ganglia growing in acellular nerve allograft. This is pictures from our lab of some dorsal root ganglia and some anterior horn cells that have been implanted in processed acellular nerve allograft and are living and thriving in that, and presumably producing axons that potentially can improve the neurotrophic environment. So this is an incomplete story. I'm just telling you how we've gotten to this concept. But most of the studies that you look at with improving the function of allograft involve some sort of injection of Schwann cells if you're going to do cellular therapy. And I would argue that the problem is not the Schwann cells, the problem is the environment. And if you're just injecting Schwann cells into the bad environment, they are also going to just enter the same senescent state that the Schwann cells that were already there had entered. So anyway, I think this is a cool concept. Obviously, a lot of steps to clinical translation, but that's another area that we've been developing in our lab. This idea is my favorite. This is my favorite thing that we've been working on, and I've been working on it for years. As you saw, I feel fairly strongly that there's a lot of nerve repairs that are not done well, that the fascicles are not well aligned, meaning not necessarily pointing towards the correct fascicle, but pointing towards any fascicle. And the concept that you can intubulate the repair and improve your results is not, I won't claim it as my idea, though I will say I championed it early on. I do agree with it. And I think that when you intubulate, it allows the surgeon to do the repair a little bit looser, and to also the wrapping of it almost splints the fascicles and helps them point towards each other. For those two mechanisms, I do think that this concept is good. And as part of the study, I showed you those fascicles pooching out of the side of the sutured cadaver nerve. Here's the group that we used a connector assisted repair. So there are a couple stitches holding the nerve ends together, but it's intubulated. And I mean, you could see the picture. It's obviously a well-aligned, markedly better repair. And we showed this statistically, that if you did this, you had a higher chance of a technically better looking repair. Cadaver nerves, we can't say how that translates clinically. We can say that at least theoretically, there are some other potential advantages to this intubulation, that you get accumulation of neurotrophic factors, you block scar tissue from invading the coaptation, you block axons from escaping. There's a little bit of data behind the theory of preventing axons from escaping. A couple of studies have shown less pain at the repair site or fewer neuromas, both of which are felt to be related to axons escaping at the coaptation. I have at the bottom thing there, allows end organ specificity. There's a theory that, as I mentioned, the body doesn't do a great job of telling the axons where to go, but maybe it can do it a little bit. And this theory is that if you give a little tiny gap and give the axons some, I guess, room to work, if you will, that some of the axons will find their way to the correct target just by doing that. I would acknowledge that that's a much more controversial theory, and I don't hang my hat on it, but it's interesting enough to think about that I'll mention it. And here's just a clinical example. You can see I slid a nerve connector onto one of the stumps. I've done my repair. It's a good repair. It's not perfect, but it's good. And then when I slide the connector over it, it really helps shape any remaining overlap and helps the nerve really be well aligned with its distal nerve stump. And if we go to the literature, you can see that the very least you get less pain at the repair site. One study has shown the superiority of connector-assisted repairs, if you will, versus direct repair, but most studies show probably at least an equivalency. But I think it's a sound concept. With that said, it can still be difficult to get the conduit around the nerve or to suture it in place. I definitely think there's a chance that the connector could be too tight, and you haven't gotten away from sutures, both with the technical aspect of suturing as well as the potential for scar tissue. So many years ago, we came up with this idea of kind of combining the concept of intubulating, but getting away from sutures, which I feel are, if nothing else, are very time consuming, even if you argue away all the other points that I've made about it. And so this will convince you that I'm not an engineer. These are actually the original drawings that I did to try to put my idea down on paper so I could show somebody else and relay my idea. So you imagine distal nerve stump, proximal nerve stump on my drawing there, taking a piece of inert backing with a bio-inert adhesive, put the nerve stumps on there so they're facing each other, and then put another piece on top to sandwich it in. Remarkably simple, and I think you could immediately think of, yeah, if that worked, that would be really nice. Well, the backing is actually kind of easy to come up with. We've been focusing mostly on this. This is a commercially available product made from pig intestine, but it's flexible, it's bio-inert, you can see through it, it's resilient, all the things you want. And then there's other similar products out there. The adhesive, though, was tough. We spent a couple years working on that, and it is tough. It has to be bio-inert, as I mentioned. Can't be water soluble because it's wet in the body, but it has to stick to a nerve, which is mostly lipid based, and that is a tough nut to crack. I'll tell you. We spent a couple years working on it. This slide, I'm just trying to show you basically just for a second. Pay attention to the all the gibberish on the right side of the screen. That table I cut out of a review article. And I know you can't read it, and I don't want you to read it. I just want you to see how many studies are on there. That is just the list of studies. This is published in 2017. So as of 2017, the list of studies of people trying to develop adhesives based on muscles, not muscles. Look how strong I am. Muscles, the clam-like little animal that secretes the adhesive. So you could imagine there are literally hundreds of studies either going on now or in the past that have tried to crack this nut, not necessarily just for nerve, but including for nerve, and it is tough. And we realized pretty early on that we were going to need some sort of mechanical hold to add to the nerve. So this is very early stuff here. I'm just kind of taking you down the trip of how the voyage of how we developed this. We did have an adhesive at this time that was, I thought, fairly clever. It was a a copolymer polylactic acid polycaprolactone that was produced as a wax. So you heated it just a little bit and it got really tacky. Now the problem is that your temperature window is so narrow that we probably, if we really used it, we'd probably have to cook all the nerves that we fixed. But it was the closest that we came to any legitimate type of adhesive. And we started looking at hooks. And these are the tiniest hooks I could get at the time. But you could see, while they may be small for fishing, they are huge for nerves. And we subsequently went and I found this guy who made these little hooks for me on a website called Trout Nut. Essentially, it turns out that if you are really into fishing, then your girlfriend probably wants jewelry with fishing hooks built into it. And so this guy would make fishing hook jewelry for people, guys, I assume mostly guys that were really into fishing, to be able to share with their girlfriends. And you could see this is a much smaller hook. We were able to get them into the backing. The guy charged me $10 per hook, and he'd send me 10 at a time, and I would immediately drop 9 of them on the floor and never find them again. But it had at least showed the potential, but not enough. And we really kind of fizzed out for a couple of years until I came across this company that was making micro needles already, and they were interested in making implantable electrodes for muscles. So they had these discs with all these little micro needles on them, and after we exchanged all the proper paperwork, they sent me some of these micros. So this is the very first experiment that we did. Oh, poop, is it not going to play? Maybe it won't play, guys.
Let's see. I think it may play.
I just pressed it funny. So this is the very first time we had one of these micro discs in our hand, and you could see, I mean, this thing's grabbing the nerve like crazy. Look at that. So we got kind of excited. We knew we were onto something, and we could see this is just showing that it's grabbing the outer epineurium. It didn't go into the fascia.
Enjoying surgery. It's a very coveted professorship. Here,
can you please mute yourself, whoever that is? Thank you.
So this is
caller number 3. I'll mute you.
So of course we can't put metal discs to hold nerve ends together. So we conceptualize now incorporating these as micro hooks inside the backing that we would put in. And if you do that, you actually get some other potential, at least theoretical advantages. We know there are some studies out there. Some of these, by the way, again, because I know you have Jamie Bertelli talking to you next week, he did some of this work as well, that you can distribute the tension away from the end of the nerve, and it can improve the potential for axon growth and elongation across there. We also showed, by the way, that fit does matter, that a conduit that fits well is going to work better. I won't belabor this, but the upper right corner, group B, you can see that conduit is too big for that particular nerve that we're fixing, and the results showed it. The histology was bad. You could see that there's much poorer nerve regenerate in that than compared to the other groups. So you get tension distribution, you get a perfect fit, and we really thought that we had a cool idea here. And I'll just take it kind of quickly through the development to where we are now, that this is some of the earlier backings that we first put in polycaptone just to kind of test it. I'm not going to take you through all those pictures. I think I've already been a little too chatty. But I'll tell you that with time, we saw that the micro hook had to look more like, we call it a shark fin type shape, or a sawtooth shape that you see in the bottom there, which we were able to obtain by cutting the metal and then twisting the microneedle at a plane. And you could see here's some, again, our earlier prototypes when we first started using that. You wouldn't want to put this on your nerve, obviously, because it's crimping and it's obviously, but this is very early on, and it's just showing that when we put this stuff on, I mean, these are little tiny 400 micron long microneedles. I mean, they are tiny, nothing little needles, but enough of them grab, and you could see you really get a good hold. Here's the same stuff with that Kapton backing. This is not an implantable type of implant, but just showing this really terrific mechanical hold, multiple micro hooks clearly grabbing in multiple areas on the nerve. And this is because I'm now working with engineers. 2 years of, I mean, every type of modification you could think of. You know, well, what if we move the micro hook 3 microns to the left? Kind of detailed changes. And what we ended up with was very similar to what we started with, to be honest, after all that time. This is one of the earlier implantable quality nerve tapes. That's what we call it, nerve tape. You could just see it wrapped around a nerve there. Here's how we envision it being used. You can see those are 2 cadaver nerves. Put one stump on, give it a little backward tug, kind of do the same thing on the other side, and then wrap it around, basically. This is that material wraps a little bit better when it's wet. And then this surface tension from the wrapping was enough to hold it shut, which we really liked, because we felt that this intubulates, but gave it the ability that if the nerve end swelled, that wouldn't be a problem. And this is what the repair looks like up close. Undoing it, you could see that by reversing the traction, you can undo the microhook grabs. Here's some of our early work putting it into a rabbit tibial nerve. You could see we've got one stump on one side of the nerve tape. There's the stump on the other side of the nerve tape, and we wrap it. I mean, the whole repair takes literally 30 seconds for us to do this. And that's what you can see coming back and looking at it a month later. No slippage, no significant inflammatory changes. 3-month harvest, just to show that there's not a significant inflammatory response around it. And rabbits do have a strong inflammatory response. This is sutures, not in a cut nerve, just in the side of a nerve. And so this is the inflammatory response from sutures compared to the inflammatory response I just showed you. Certainly, if nothing else, not any worse. Just showing that when we put the nerve tape on intact nerves, it didn't seem to hurt the nerve. It didn't have a negative quality. And this is some of our early rabbit outcome stuff showing better axon counts with the nerve tape when we did that tibial nerve repair I just showed you. Other parameters equivalent to sutures, but certainly what we felt was very promising. And when we went back and we were self-critical, and we took a ton of pictures of everything we did. We went back and we're looking at the pictures, and we think that we see that there's still a little crimping. This initial prototype, we used stainless steel for a variety of reasons. And while the stainless steel, when you cut it so finely, yes, it's flexible and it moves, but it does still potentially crimp. And here's kind of an example where you could see, yeah, I could see that could be a problem with the stainless steel. So we switched to nitinol, which is a much harder metal to work with, but doesn't crimp. And that's what we want to avoid. We want to avoid crimping. Here's some kind of more recent applications of the newer versions of nerve tape with the nerve stumps being placed on the nerve tape. This is the nitinol, the newer version nerve tape, showing it wrapped. Coming back, here's a 1-week follow-up, just showing that it's held the repair for a week. This is, I think, a very important slide, because whenever I talk about this with anybody, they're like, the micro hooks are going to destroy the nerve. Well, this is histology showing this is the micro hook right here. Okay, and we measured it. We know that it's exactly 425 microns long. That's how long the microneedle is. Here's your fascicles over here. Here's your axons over here. So we are not, even with that tiny nerve, we are not penetrating into the fascicle, just showing that that's very flexible. It'll rebound. Strength was the same or stronger. Once we had the nitinol prototypes, the nitinol prototypes were stronger than sutures. This is just from a few weeks ago. Just again, we're still tweaking the final design. We're just about a design freeze, but we're playing around with a couple of final things. And you could see that I literally cannot pull this apart. That I'm pulling very hard. You can see it's given just a little bit, but obviously I'm pulling very, very, very hard there. So, and I think that's cool. And that's my favorite. That's my favorite thing that we're researching. I truly believe that will make it to market, and I believe it will certainly help some surgeons really get more consistent, better nerve repairs. And that's what I kind of consider my baby, to the point that I'll sheepishly admit to what do we got, like 50 random people that I don't know. So I'll sheepishly admit to you that I actually now have on my license plate NRV TPE nerve tape. So that's kind of my research baby. I'm going to finish though with what I think is the most potentially impactful idea, and I won't claim that it's mine. I will tell you that people have been working on this idea again for several decades, particularly a guy named George Bittner at a University of Texas in Austin. Recognized that polyethylene glycol hydrogel, which is ubiquitous. It's all over. Even if you don't think you've seen it, I guarantee it has seen you. It's in everything. A lot of medical products, a lot of non-medical products. It's all over the place. If you have the right concentration and you take a cell and you cut the cell, you can apply this stuff and the membrane around the cell will refuse. It'll heal back together immediately. Well, if you think about it, an axon really is just the extension of a cell body, and the axolemma really is just cell membrane. And based on that, if you cut an axon, get it lined up well enough, and put PEG fusion or the PEG hydrogel around it, it should be able to fuse that axon back together. And indeed, starting with very simple animals such as crayfish or earthworm type stuff, and then eventually working its way up to small mammals, this works. When I first heard it, I said, no way, that can't possibly work. But at least in these small models, it definitely can work. That you can restore the continuity of a nerve immediately, meaning no other energy generation, meaning you've restored physiologic function to the two halves of the cut axon that you've gotten back together. And obviously, you have to do it in a timely fashion, which may mean that all of a sudden cut nerves that we used to blow off till our next OR day now may get done in the middle of the night if this ends up working in humans like we hope it will. But it clearly has the potential to be really the first truly revolutionary advancement in nerve therapies. With that said, why am I showing this in my list of things that we've been innovative for? Well, the problem with the PEG fusion, there's two problems. One, you have to have the nerve ends perfectly aligned, like the axons obviously have to be very close for this PEG fusion to get them to kind of jump back together and fuse into one axon. And I just showed you a ton of pictures showing you that a lot of surgeons aren't going to be able to do that. So nerve tape, if it works the way that we think it's going to work, nerve tape will help people do that. It will improve the quality of the repairs and improve alignment. The other problem with the PEG fusion is that the fusions are very fragile. So in the animal studies, they get the PEG fuse, they let the rat run around, and there's actually a decrease in the axon counts in some of the rats at between 1 and 4 weeks, where presumably some of the fused axons are breaking. And we know that this is not a very strong bond between them, so you have to have a lot of stability to support the repair, and nerve tape, obviously, as you could see up in the pictures, is going to be able to provide that level of stability. So we're kind of jumping on an idea that's been out there and under development for a long time, though we kind of think that we may be a key part of them being able to translate to clinical usage, which is very exciting. This is a pig ulnar nerve, and we're doing a PEG fusion on the pig ulnar nerve. So there's all these steps where you freshen the nerve ends, you wash it with hypotonic calcium-free saline, then you basically apply the PEG fusion, and then apply a calcium-containing solution. And this is just showing, though I shouldn't say just showing, because it's really cool that you can now do a very low stimulus proximally. You're getting a distal compound action potential, and in the little piggy foot, you can see the intrinsics are firing. So really, to me, the potential for a true game changer. So that's kind of what I have for you. Hopefully that was at least entertaining and interesting. Some ideas for you to think about. And anyway, Babak, I'll welcome any discussion if we have time for it, or any questions, or we could talk about any other related topics if you want.
Great, thank you so much, Jonathan. I've heard you give a lot of talks over the years, and this is, in my opinion, the best talk I've heard you give. So congratulations, that's really good. And also just a really great overview, especially that first half on just the basics of nerve repair and the obstacles that we currently have to good nerve regeneration. A quick question I have for you with regards to the nerve tape. First of all, you and I have talked about this nerve tape because obviously you've been on this for many years, and I hadn't seen the most recent advances in the pictures that I just saw now. So congrats on it. Looks much better and a really nice product. What is the FDA pathway for that? Obviously, the Axoguard nerve protector material and everything is already approved, and we're using it. You're adding these nitinol hooks to it. Do you know what the pathway is for that?
Well, obviously that's a big topic of discussion for us because it's actually an interesting topic because people I don't think really understand what goes into developing a product, which is one of the reasons why I kind of show all the extra slides about all the steps we took to get to where we are now. I just think people don't appreciate how hard it is to develop something. But these regulatory pathways are a big obstacle for sure. And if we cannot 510K it honestly could be dead in the water. It may not be an idea that could generate enough money that anybody will support us going through a full regulatory process. But we think exactly what you said. We think that it has enough similarities to the current stuff on the market that we're going to be able to 510K it as a different form of a connector or conduit.
Yeah, I think that'll be key because a PMA for this would be a very kind of cost prohibitive.
People use nitinol in the body all the time, and the concept of having metal around nerve tissue. I mean, the neurosurgeons put 1 million metal clips in people's brains. I mean, these ideas are okay logically. Now, whether or not when we talk about them to surgeons and they get a visceral response, that's hard to say what's going to happen. And it is possible that surgeons won't accept this, even if we feel like we've demonstrated that it's a good idea. So I'm not saying that that's why I say I think it'll go. I'm confident it will continue to develop, but who knows what'll happen when people really start looking at it.
Hey, Jonathan, thank you so much. Greg Buncke here. Hey, I'm wondering, love the nerve tape idea, but also about this PEG fusion. Can you give us some long-term follow-up on that? The motion of the pig, did it continue to move later? I mean, or did you have to get rid of the pig right away?
That pig did not make it. It was unfortunately we couldn't pull the pig through, mostly because it was not set up as a study that way. So I don't know, and that's a big problem with this concept is that when you getting a rat sciatic nerve to fuse together versus a pig or a polyfascicular nerve, more indicative of what I think all of us could see as the potential of PEG fusion, it's different. And if you even stop to think about it for a second, you say, okay, as you're putting this PEG on there, it will actually, if the axons are not closely approximated, this stuff will actually fuse the end of the cut axon. Okay, so you could imagine that you could fuse, just theoretically, you could fuse the outer rim of the nerve and the entire center of the nerve may not fuse, right? Or it could drip in there and you have groups of axons that are separated, and it won't block axons from regenerating. They'll still heal as if they normally would. But you could see why this is really cool. And it was so, when I first learned about it and after I got over my disbelief, it's so Star Trek that you can't stand it. You're like, holy blank, we can potentially, do a procedure and a person has almost immediate recovery. And so to me, that's so exciting. With that said, your skepticism is appropriate. This is something that really, it may not end up working in bigger nerves. But I think that if it is gonna work, it's gonna take something like our innovation. There is definitely some funded studies coming out of Johns Hopkins in San Antonio over the next 5 years or so. I mean, it's gonna take a while to collect this data, where they're both gonna do it in bigger animals, but with long-term follow-up, pigs and non-human primates, as well as initiate a clinical study as well.
But theoretically, you don't need the long-term follow-up because it's supposed to the nerve is supposed to work immediately, right? Is that true? Has anybody done a put some peg in a pig and actually allowed this pig to survive and see if the leg works or the fingers of the leg of the pig work?
They've only done the kind of stuff that I showed you, that we play around with it and say, look, we think we have peg fusion, we think it's worked. In the rodent model, yes, they've done that, and they show that they have, you know, walking track analysis, and they could say, look, it's still, you know, the static function index is so much better than when we don't do this. And then they go back and they do axon counts. They say, look, the axon counts are so much better that you really can only explain it that peg fusion took place. And so I think it's compelling data that when I say it can work, it's very finicky, and there's clearly a huge learning curve. I mean, a huge learning curve. Again, one of the reasons why I say it's going to take something like our help to really become truly successful. But your question is, has it been shown in a big animal to really work? No, it has not. But in a small animal, it's very compelling, I think. And the stuff's being done now. So the next, or just starting to ramp up. I know that several big groups just got funded to further develop this. So I think it will get developed anyway.
Great. Any questions from the audience? If you do, feel free to unmute yourself and ask away. Looks like we don't have anything being asked in the chat section. So, Jonathan, thanks again for giving us this really interesting overview of peripheral nerves and also all the innovations that you've been working on. It's really impressive to see, and we look forward to kind of following it over the next few years and hopefully be able to use it. You know, the nerve tape itself, it's like you said, is very similar to Jamie's, how he was using the mesh to advance.
So sorry, say again.
I think it take tension off of it. It's just much easier, and it shows a lot of promise.
Yeah, I think it'll
well,
be.
Thanks again for being with us. Hope to see you again. Hope to see you. Sorry, go ahead. I think there was a lag there. Sorry.
I know.
There's a bit of a lag. I'm sorry. But anyway, it's great to see you virtually, and hope to see you in person soon.
Yeah, thank you. Thank you for giving me the opportunity to talk to you guys.
Excellent. Great. Thanks. Take care. Have a good day.